Recording has started. Over to you.
Well, a warm welcome to everyone for the cardiology clinics for this coming month. Uh, this time we had a little delay due to some unavoidable circumstances in the first week of October. But we do run the cardiology clinics on the first week, on the first Friday of every month from 3 to 4 p.m. And as everyone knows, this is our 15th or 16th cardiology clinic in succession, where we've had regular sessions of teaching in terms of cardiology and updates in cardiology on very selective and very to the point topics. Now, today we are moving towards an interventional topic. We've had topics in the past on dyslipidemia, hypertension, heart failure. We've had some interventional topics earlier. We've had antiplatelets. So we've covered a large spectrum of cardiology. Today we are going into a day-to-day problem which a lot of clinicians face, which is in terms of STEMI and the diagnosis of STEMI, and how STEMIs are not straightforward and how they can confuse us. So we have a very prominent speaker, Dr. Nilay Patel, who I will introduce after we have our introductory videos. Nilay has joined. Uh, we are uh, uh, going to talk today on STEMI mimics and STEMI equivalence, and then so there will be a 20-minute to 30-minute talk on this by Dr. Nilay, and followed by that we will have question answers, which we encourage everyone to put on the chat box. But let me start by thanking Jaslok Hospital and API, the Association of Physicians of India, for this collaborative effort on cardiology clinics. And they provide us the platform while we do the academic content. So we will start by playing three messages back to back. One is a video on Jaslok. The second is a video of the ex-president of API. And the third is a message from Dr. Ashwin Mehta, the director of cardiology at Jaslok Hospital. Can we have these three messages played? The Jaslok video, Dr. Milind Nadkar and Dr. Ashwin Mehta.
Sure.
In a world of constant innovation and advancements, there exists a beacon of healthcare excellence that has stood the test of time. Jaslok is one of the oldest quaternary care multi-specialty hospital in India. With 350 patient beds that has been transforming lives for over 5 decades. Jaslok, conceptualized and endowed to the city of Mumbai by Seth Lokumal Chandray, that brought the quality of international care to the doorstep of India. The facility was inaugurated on 6th July 1973 by the erstwhile Prime Minister Mrs. Indira Gandhi.
Jaslok Hospital has been a trendsetter and pathfinder since then onwards.
Institution has established many centers of excellence, providing world-class treatment and care to patients. Our commitment to delivering the highest standards of care and our patient-centric approach has been the cornerstone of our success.
Humanity and care have always been at the core of everything we do at Jaslok Hospital. Trust is the foundation of Jaslok's success.
We are proud of our legacy, a legacy that has earned us the trust and confidence of countless patients and their families over the years.
With all these full support, care at the level of humanity, at the level of science, Jaslok Hospital has done a human service.
Jaslok attracts a significant number of patients across the globe and plays a major role in medical value travel. We are known for introducing future-ready medical technology that offers the most advanced diagnostic, surgical and therapeutic options. Jaslok is also a teaching institution and conducts postgraduate courses in several specialties and is recognized by the National Board of Examinations. Over the past 5 decades, our hospital has achieved numerous milestones, establishing itself as a leader in medical research, education and innovation.
At Jaslok, it's always about patient first. Apart from the best medical care it provides, Jaslok Hospital is known for its ethical practices and human touch. The summary of past 50 years is about the care, compassion, and excellence.
The infrastructural transformation that is currently underway aims to give a new face and shape to the hospital. Jaslok 2.0 promises to take patients and stakeholders' experience to the next level.
Jaslok Hospital and Research Center is known for its warmth, its empathy, its specialized care that all the team and all the doctors, all the non-medical staff, the nursing staff, and every single Jaslok employee takes of patients. This is our USP.
As we celebrate our 50-year journey, we express our heartfelt gratitude to the patients who have entrusted us with their health, our eminent doctors and dedicated staff who have tirelessly served the community, and our partners and stakeholders who have supported our vision.
Jaslok has always believed that healthcare should be accessible to all, and we are sure to continue to provide the highest quality medical care and maintain the leadership position.
Together, we embark on the next chapter of our extraordinary journey and remain committed to our mission of providing world-class healthcare with compassion, integrity and innovation. Jaslok, pioneering healthcare for over 50 years, a lifetime of care.
Thank you so much. And we have the message from Dr. Milind Nadkar, the ex-president of API.
Welcome all. I am Dr. Milind Nadkar, President of Association of Physicians of India, API. It's my proud privilege to address you on this occasion. As you all know, cardiovascular diseases are on the increase in India. With increasing incidence of diabetes, we are now heading towards a major cardiovascular disease epidemic as well. To address this issue, we have got these cardiology clinics designed by Dr. Nihar Mehta in association with Jaslok Hospital. I think it will go a long way in saving not only our old population with cardiovascular disease, but also our young population, which is under now a great threat of cardiovascular diseases. I congratulate Dr. Nihar Mehta for these clinics and best wishes to him and all the participants to gain a good knowledge to tackle these cardiovascular diseases, which are threatening to be the most important single cause of deaths due to non-communicable diseases. Thank you very much.
Thank you for your kind words and blessings to Dr. Milind Nadkar. Can we have the message of the Director of Cardiology at Jaslok, Dr. Ashwin Mehta?
Congratulations, Dr. Nihar Mehta. This is a great initiative. You know, every day there are 600 cardiac journals published, and cardiology clinic is not one more addition. Because I know Dr. Nihar Mehta is born teacher. And why do I say that? Because his late father, Dr. Pradeep Mehta, was a great academician, and his grandfather, Dr. J.K. Mehta, also an esteemed teacher. You know, cardiology clinic is going to give you an abridged review on the state-of-art practice in cardiology today, and Nihar is going to give us on a platform all the ready-made literature, making it easy for cardiology community. Nihar, I know that this is an initiative, and I wish you many more innovative ideas to come into practice from you. Good luck, Nihar.
Thank you.
Thank you so much. Well, let's get into our webinar right away. Let me start by introducing our speaker. Dr. Nilay Patel is right in the beginning. Let me say he's a very close friend of mine and a close colleague. We worked together in Jaslok Hospital in the past. Now, done his fellowships in interventional cardiology and structural heart disease from various places in India as well as all over. a very accomplished cardiologist, and he works between Mumbai and Vapi, Valsad, sorry. And he's one of those doctors who's facing these as we come towards cities nowadays, we are seeing less and less STEMIs because there are a lot of cath labs in the peripheries, and they are filtering out STEMIs and acute coronary syndromes. So we get a lot of chronic cases compared to what you see in the peripheries. And Dr. Nilay is one of those doctor who has a mix of both the worlds. He's prepared this talk on STEMI mimics and STEMI equivalence because, as we know, the ECG of ST elevation can sometimes be very straightforward, but very often it is elusive. It is something which can confuse us, and it is an essential diagnostic kit to distinguish between a life-threatening STEMI versus something which is not as acute, like GERD or muscular pain. So we'll have Dr. Nilay Patel give us his talk over the next 20 to 30 minutes, and we'll follow that with question and answers. So Nilay, thank you so much for being here. If you can share your slides and take us through the STEMI mimics, and we will take it forward.
This is okay.
Looks great. Just go on to presentation mode.
Right.
Yes, the screen is visible.
Am I on the presentation mode?
Yes, doctor, you are.
And am I audible also? Audible enough?
Yes.
Yes. Good afternoon, everyone. And thank you, Dr. Nihar sir, for giving this opportunity to talk on a very important topic, which is STEMI equivalents and STEMI mimics. Thank you, sir, for giving this opportunity. And as you rightly said, it can be very elusive, and it's a matter of life and death at the end of the day. And that's why I want to run through something very interesting and important. Our brain is primarily a pattern recognition organ. It generates pattern, it maintains pattern, it perceives pattern, it processes pattern, and it seeks pattern too. And it's primarily a pattern recognition is one of the many pattern things that brain does. And it does it through visual input, and it can have very complex neural pathways in which it recognizes a pattern. Having said that, there are lots of patterns that we recognize daily in and out. The meteorological department, for example, it recognizes the patterns of the clouds and the weather, and then decides, yes, that's the very important. After having recognized the pattern, they need to make a decision. Likewise, in the stock market, everyone's looking at patterns. If you see the population growth curves, there are patterns. There are circadian rhythm and circadian patterns. And as we see with the heart, we have the heart monitoring system, which recognizes a certain pattern. There are patterns in nature. There are fractals in nature, which are scalable, which are self-repeating patterns, which maximize distribution and surface area, like we see in the coronaries. And there are branching patterns in the nature. So essentially, we are dealing with patterns, and that patterns help us recognize. However, there are black swans. What are black swans? So this concept was given by Nassim Nicholas Taleb in his fantastic book, which I happen to read. It's called The Black Swan. Black swan, the first time the term was given in 2007, it describes rare, unpredictable events that have massive impact. There are three main characteristics of a black swan event. One, rarity. These events are extremely rare and unusual and lie outside the realm of normal expectations. There are extreme impact. When it occurs, it has a huge effect on markets, societies, and on individuals. And retrospective predictability, which means hindsight bias. After it happens, people try to rationalize it as if it was predictable. Why I say this? Because we are going to deal with such a situation where we have had seen paradigm shifts between STEMI and NSTEMI, which started when it was formally replaced, when it formally replaced Q wave versus non-Q wave MI paradigm. It looked at a study of 60,000 ACS patients in the reperfusion era, where the algorithm was quite simple. It is ACS, you see an electrogram, you see a Q wave MI or a non-Q wave MI. Then you decide whether it's STEMI, which is ST elevation, or an NST elevation MI. However, STEMI is an inadequate terminology. Why I say that? Because STEMI, when we say that, that only we assume that only ST segments matter. We assume that ST segments are reliable. We assume and don't depend on the preceding QRS complex, and that ST elevation on the ECG is the only necessary data point for making the reperfusion decision. And thereby, ST elevation MI is an inadequate terminology. Why? Because there needs to be a paradigm shift in basically answering two questions. Is the patient having a STEMI is not anymore the correct question to ask. The real question that we should be asking is, does the patient have an acute coronary occlusion that would benefit from immediate intervention? And that brings us to two terminologies, which is occlusive myocardial infarction and non-occlusive myocardial infarction. And occlusive myocardial infarction is a branch of ACS algorithm representing near or total occlusion with insufficient collateral circulation causing active infarction. It will benefit definitely from emergent reperfusion therapy. However, non-occlusive myocardial infarction has no occlusion or sufficient collateral circulation to avoid acute infarction. Time is muscle. This is the first universal definition of MI in 2000. And over a period of years, across 20 years or 25 years, we have come to the fourth universal definition, which says about ST elevation MI. New ST elevation at the J point in two contiguous leads with a cut point of more than 1 mm in all leads other than leads V2, V3, where the following cut points apply. These are all standard algorithmic criteria. And this is how we localize ST elevation MI when it is septal in V1, V2, 2, 3 AVF, inferior, lateral 1 AVL, V5, V6 with reciprocal changes, anterior V3, V4, anteroseptal, anterolateral, and posterior MIs. This is the ECG, clear-cut ST elevation MI, anterolateral STEMI. This is inferior STEMI with ST elevation 2, 3 AVF with reciprocal changes. This is inferolateral STEMI with 1 AVL ST elevation along with 2, 3 AVF. Posterior leads, this is ECG, which shows inferolateral posterior MI. Which RV leads, we see inferolateral posterior STEMI. This just to give an idea of STEMI. However, we need to rethink old models where NST elevation MI and STEMI mode paradigm is not reliable tool for diagnosing occlusive myocardial infarction. Up to 30% of patients we classify as NSTEMI are consistently found to have missed acute coronary occlusion, meaning NSTMI, they look like NSTMI, but actually they are STEMIs. Although these patients often end up receiving intervention at a later stage, almost 24 to 72 hours into admission, it is usually too late to salvage ischemic or infarcted tissue, and they are exposed to significant increase in morbidity and mortality. 40% of occlusive myocardial infarction do not present with STEMI criteria on ECG. This is a study which was done, which showed that physicians' ECG interpretation accuracy for cath lab activation decisions was just 70%. In 30% of patients, they had to reclassify the ECG reviewers as having acute coronary occlusion. So what are STEMI equivalents? STEMI equivalents, a coronary artery occlusion carries a level of severity and clinical urgency comparable to that of classic ST elevation MI, although they do not meet the typical ST elevation criteria as suggested earlier. So these are the STEMI equivalents that we see: hyperacute T waves, De Winter's STT complex, Valence T waves, posterior MI, shock T waves, diffuse ST depression with AVR ST elevation, persistent pains, Garbosa criteria, and left ventricular hypertrophy. New LBBP is no longer a STEMI equivalent criteria. Hyperacute T waves, tall T waves, often asymmetrical. As you see right beneath, there is an asymmetrical T wave. Broad-based anterior T waves often associated with reciprocal ST depression. De Winter's T wave, which suggestive of proximal LED occlusion, If you see in that lead V3, there is a typical, I'm going through a couple of D Winters T inversions ECGs where we clearly see that there is a precordial ST segment depression at the J point, as you see. There are tall peaked symmetrical T waves in the precordial leads and a lead AVR which shows slight ST segment elevation in most cases. This is a typical D Winters T wave which is seen here. Another ECG which shows, if you see the precordial leads, these are the precordial. Do you see the cursor, everyone? Excuse me. Is the cursor visible? Hello? Am I audible?
Yes, doctor, you're audible, but the cursor is not visible.
Okay, just a second. I need to pointer options. I will need to. Okay, is it audible visible now? The laser?
Yes, it is.
Yeah, so if you see here, this is a typical STT wave depression, which is seen with a mild ST elevation and tall T peak waves as a sign of proximal LED occlusion. The same here, if you see V2, V3, V4, these are all D Winters T sign. Wellens syndrome is an ECG finding in the absence of chest pain, but with recent chest pain symptoms. Represents critical stenosis of LED, not necessarily STEMI equivalent, but will require PCI in the next 24 to 48 hours. In fact, no, it is a STEMI equivalent. And deeply inverted T waves, which are seen, I'll be going through a couple of Wellens syndrome patterns in the next slides. You see, this is a typical Wellens syndrome, which you see in the anterior leads V1 to V3. Same here with deep T wave inversions in V1 to V3. It's a typical this thing about LED occlusion. This is also an ECG suggestive of Wellens syndrome. Isolated posterior MI, it is a very important ECG finding that can be missed. It's a STEMI equivalent because it inevitably is seen as an occlusive coronary artery disease. It is suggestive of ST segment depression, horizontal or more downsloping, upsloping, with prominent and broad R wave, prominent upright T wave, and a combination of horizontal ST segment depression with upright T wave, as you see here in V2 lead. Posterior ECG or a 15 lead ECG may be helpful in such cases, where in V7, V8, and V9, you see ST elevation, which is more than 1 mm. This is diagnostic of an isolated posterior wall MI, and it although looks like an end STEMI, it is actually a STEMI. If you see here, you see V1, V2, V3, ST segment depression with mild ST elevation in 3 and AVF. LMCA occlusion is seen with occlusion or near occlusion of the left main artery, has been reported in occlusion of proximal left anterior descending artery and severe multivessel coronary artery disease. The significant findings include ST elevation in AVR. Let's be very, this is very important to note that AVR elevation more than 1 mm, ST elevation in AVR more than V1, and ST depression typically seen in lateral leads V4 to V6. If you see here, there's ST depression V4 to V6. There is ST elevation in AVR lead, which is more than V1. We have criteria for STEMI in the presence of LBB and LVH, which is called the Garbosa criteria. It is used to identify STEMI in the setting of LBB or a pacemaker. Original criteria included more than 3 points, 98% probability of STEMI, and more than 2 is specific for 61 to 100% and sensitivity of 79%. However, there is a Smith's modification, which is now, which changes the third rule of original Garbosa criteria to be ST depression or elevation discordant with the QRS complex with a magnitude of at least 25% of the QRS, with which increases sensitivity from 52 to 91% at the expense of reducing specificity from 98 to 90%. It's also known the rule of appropriate discordance, which was originally developed in 1996. The same principle of the Garbosa criteria also applies to LBB, RBB, LVH, paced ventricular rhythms, non-paced ventricular rhythms, and WPW, which is pre-excitation. This is the rule of appropriate discordance, where a QRS with a positive terminal deflection should be followed by a negatively shifted STT. A QRS with a negative terminal deflection should be followed by a positive deflected STT. It's quite easy to remember. An ST elevation depression should be proportional to the size of QRS. This is the deviations from this. This is the normal ST segment discordance. Deviation from this should suggest an MI, acute MI. This is a STEMI. Likewise, this is the same, which makes it with the Smith's modification, it makes it more proportional. And this is the same, if you see here, it is an ST elevation MI. The left one here is the normal LBBB. However, this one, it fulfills the Garbosa criteria and thereby is a STEMI. So that's not a STEMI. However, this is a STEMI. This is a STEMI again, fulfilling the Garbosa criteria. STEMI in left ventricular hypertrophy is single most common STEMI mimic, may or may not exhibit STG changes. Garbosa criteria works well here. True anterior STEMI almost never present in the setting of profound LBH. ST segment may be benignly convex and voltage criteria generally irrelevant to the question of MI. New LBBB is no longer a reason to activate the cath lab. However, a careful work of ACS should be taken for symptomatic patients with LBBB. And 12-lead ECG findings include a QRS in more than 0.12 in limb leads and large and wide R waves with lead 1, AVL, V5, V6. There are small R waves followed by deep S wave, leads to 2, 3, AVF, and V1, 2, V3. This is LBH criteria. So the problem with most ST elevation is it may not be an MI. That's unfortunately, ST elevation is not an uncommon finding on the ECG of the chest pain. It causes indifferently involves acute myocardial infarction. Only 15% of ST elevation patient had MI, 85% had non-MI diagnosis. Now this brings us, it's quite easy to recognize an ST elevation, but STEMI recognition diagnosis requires distinguishing MI from non-ischemic causes, which brings us to the topic of STEMI mimics. STEMI mimics means they look like STEMIs, but however, they are not STEMIs. There is a mnemonic for STEMI, which means there are of patients who present with STEMI mimics, LVH has contributes 25%, LBBB contributes 15%, acute MI actually contributes only 15%, benign early repolarization contributes 12%, RBBB 5%, non-specific bundle branch block 5%, ventricular aneurysms 3%, pericarditis 1%, and unknown undefined almost 17% of patients. So over triage is better than under triage. Maybe it's better to play safe, but there are downsides of false positive STEMI diagnosis. It weakens true positive. If there is an issue in recognizing mimics, there's definitely an issue in making a call for true STEMI. So it is very important for us to know the STEMI mimics so that we do not activate the cath lab unnecessarily. There are more downsides of false positive STEMI diagnosis because we have missed alternate diagnosis in that case. Some non-MI diagnoses are also critical, like thinking about aortic dissection, hyperkalemia. Calling it STEMI is not always playing it safe. Wrong treatment is another downside of a false positive STEMI diagnosis. We may give nitro, aspirin, or fibrinolytics where it is not indicated. Thereby, getting it right affects field and hospital treatment. We also unintentionally hamper resource utilization, and which also burdens the family unnecessarily. Left bundle branch block is the second most common STEMI mimic, traditionally either considered non-diagnostic or de facto evidence of MI. AHA still recommends fibrinolysis TPA in patients with signs and symptoms of ACH with a new or presumably new left bundle branch block. It's because they have the highest mortality rate when LBBB is due to extensive MI. Left bundle branch block, how? You already know it. We can diagnose it with the Garbosa criteria. That's what it's for, and we know it works. We have serial ECGs. If usually uncomplicated LBBP are electrically stable, We must have an old ECG. If the patient does not have, it's a good idea to ask them if they have an old ECG. Old LBB versus new LBB does not change the probability of MI, but if there is an old LBB, you can compare it with the old ECG and compare it find versus the new findings in the acute changes. Right bundle branch block is the fifth most common cause of STEMI mimic, usually easier to manage as it often does not elevate the ST segment. Like LBB, morbidity and mortality may be very high when acute MI is associated with RBBB. Principles are the same. Use Garbosa criteria. Remember to base discordance on terminal QRS deflection. Watch out for posterior reciprocal changes, deepening your normal ST depression. Right ventricular hypertrophy, the same. Use your Garbosa criteria. Generally, most evident in V1 to V3, generally has right axis deviation and presence similar to posterior MI with reciprocal changes. So keep a watch out. Benign early repolarization is the fourth most common STEMI mimic. Some degree of benign variance, very common in healthy population, most prevalent in young, decreases in frequency with age, and may be especially noticeable in athletes. Bad news is very common, non-specific ECG characteristics. The good news is changes are generally limited to a few specific features. I'm not going to in the details of early repolarization syndromes, but typical ST ECG findings include ST elevation focused in anterior precordial reads that is not too profound, is concave, may have a notch J point. Permissible ECG findings include large, slightly asymmetrical T waves, some movement of ST segment or T wave on serial ECG recordings. Benign early repolarization are always associated with well-developed R waves, is almost also associated with a short QTC. So if any of the two following are true, it is MI with a sensitivity and specificity of 90%. Should not be present with MI, should be no reciprocal changes. There should not be any convex ST segments, no pathological Q waves, no acute evolution, no clinical signs or symptoms. In short, except for ST elevation and big T waves, it shouldn't look like MI. Ventricular rhythms, spaced ventricular rhythms, only rhythm other than LBB with empirical support for Garbosa criteria. Do patients with pacemaker have heart attacks? Of course, there's nothing new here. We follow with serial ECGs. We use our clinical acumen, and also a typical pacer lead placement, not in apex of the right ventricle, may not fit this model. These are examples of paced rhythm with acute MI. Left ventricular aneurysm refers to persistently after effects of a previous MI, which often includes chronically elevated ST segment, may or may not actually entail aneurysm, can present essentially identical to MI since that's what it was for, and somewhat more common in anterior leads. Look into the past history. Past medical history includes prior MI, or if there is an old ECG available. The biggest clues are Q waves. This is an old infarct and should therefore exhibit pathological Q waves. Look for substantial negative QS waves with no notable R wave. There are no exaggeration of the T waves in such patients. In other words, compare QRS depth to T height. The first should be relatively large, the second relatively small, otherwise suspect in acute MI. These are typical cases of LV aneurysm. Pericarditis, inflammation of the pericardial sac, often infectious. The clinical signs which are suggestive, although not specific, like chest pain that may be sharp and pleuritic, pain elevating by sitting up or leaning forward, may be accompanied by signs and symptoms of infection. Our pericardial rub can be appreciated on auscultation and no relief in nitro. Initial ECG findings are diffuse, non-localized ST elevation, no reciprocal changes, widespread PR depression, and morphology resembles benign early repolarization. Generally, approach is similar to that of the BER. The disease process produces 4 distinct stages on ECG over hours or days. First stage is ST elevation. Second is normalization. Stage 3 is T wave inversion. And fourth is normalization, depending on when you see that patient. These are causes. This is how pericarditis would look like on an ECG. So despite we have to know the clinical context, These patients will usually look terrible, so will their rhythms. However, the pericarditis should show ST depression in AVR. LCA patients typically exist ST elevation instead. Despite their acuity, LCA patients need a facility with PCI and CABG. Thrombolysis is not beneficial, and mortality can be very high, over 70%. Less common STEMI mimics include Brugada syndrome. It's a risk factor for sudden polymorphic VT or VF. It was initially described in 1992, and it has genetic predisposition to it. Sudden unexpected death syndrome in young males in Southeast Asia, commonly seen in Brugada. Risk of sudden arrhythmia and possible death, and the treatment is EP study plus automated defibrillator to be implanted. There are ECG findings which suggestive of ST elevation only in V1 and V2, sometimes V3, with particular morphology. RBB or similar appearance. Appearance may fluctuate over time, and ECG changes may be inducible with certain anti-arrhythmic medications. The hallmark morphology is most visible in V1 and V2, that's for sure. This is how type 1 Brugada would look like, with ST elevation features seen most prominently in V1 and V2. The bottom line is we have to learn the basic morphology of Brugada, screen it on all ECGs, make it a part of your differentials for syncope in young healthy patients. If suspected, monitor continuously and transport to a cardiac care. Brugada may look an evil twin of the benign early repolarization syndrome. Your 12-lead ECG may be the only chance to catch a young asymptomatic Brugada patient early. We can also shift the leads upwards in the first intercostal space to have a better look at the Brugada. Brain injury and intracranial hemorrhage can also affect the ECG, which could lead to myocardial stunning, and that could lead to neurogenically mediated vasospasm, and that could lead to STD changes which look like MI, but they are not MI. The bottom line is, primary point is not to be confused. If you see ECG abnormalities when assessing the brain injury patient, consider the circumstances, but likelihood of concomitant ACS is very low in such patients. Monitor for cardiogenic shock. Patients may need cardiovascular support in immediate injury period. Thoracic aortic dissection. The diagnosis is very critical because of its high mortality. With each hour, the mortality increases by 10%, and the potential rapid deterioration, complicated by similarity in presentation of acute MI, which can include ECG findings. Mechanism of ECG changes is physical impingement on coronary arteries from retrograde dissection. It is not through ACS. It is very important. The bottom line is a very difficult and high stakes diagnosis that still has no good solutions. Only surgical interventions can save such patients. Have a high index of suspicion when in thoracic aortic dissection patient should be on your differential diagnosis with patients, all patients of chest pain. If history and clinical picture leans towards thoracic aortic dissection or MI, weigh the risk benefit and get to a hospital very early. Vasospastic angina, very idiopathic disorder, distinguished from typical angina by its arbitrary onset, unrelated to exercise, often occurs in setting of CAD but produces symptoms disproportionate to degree of stenosis, typically benign unless very severe. ECG findings suggestive of ST elevation, but typically slight, but occasionally severe, sometimes T-wave inversions, transient duration. It's very important. It is atypical, but it's typically atypical or not, it's angina. It will look and act like angina. Nitro will likely be very effective. It will pass one or more reason for CL ECGs. Signs and symptoms last for 10 minutes plus, starts to point, if it is more than 10 minutes, it starts pointing towards acute MI. May not be distinguishable from aborted or stuttering MI. WPW syndrome, we need to find the morphology on the ECG. The bottom line is start by recognizing the pre-excitation. Carbozaccardia actually works in most cases, but not reliable. Each accessory pathway is different and conduction is unique. If diagnosis of WPW is clear, be skeptical about STEMI. Symptoms are much more likely related to arrhythmia than MI. This is how a WPW would look like with a delta wave, which is seen. Hypertrophic cardiomyopathy, you can see what is apical, especially apical hypertrophic cardiomyopathy, presents with deep T-wave inversions from in the anterolateral leads, and the findings can be corroborated with that of with symptoms as well as on the echo. Hyperkalemia manifests with ECG finding that resemble ACS. ECG presentation may correlate unreliably with level of serum potassium, may require immediate field treatment and management of arrhythmias. History should be suggestive. For example, patients with chronic renal insufficiency is a major risk factor with patients who can have hyperkalemia, and that can reflect on the ECG. Early signs is hyperacute T wave, which classically appears as fairly symmetric, narrow at the base and slim, with a sharp point with a concave STA segment. This is the ECG, which is how it looks on with hyperkalemia. If the potassium is 7.1, this is how it would look. If you see here, if you can appreciate this better. With potassium 8.5, it could look this much, and with 0.9, it could look like this. So acute bottom line is hyperkalemia should be in your differential for every known dialysis patient with general complaints of altered mental status. Most diagnostic early ECG change is T-wave morphology. More advanced stages may be less clear, but then it should be obvious there is something other than MI going on. Guard against arrhythmia and manage acutely the renal issues at hand. Takotsubo cardiomyopathy, it's an interesting entity. We can find these patients in infectious disease wards, in other patients undergoing surgery, etc., where there is some sort of stress, even bad news or emotional stress, or a physical trauma or medication can cause this. Can resemble acute MI in early aspect, clinically ECG and biomarkers. Primary diagnosis occurs when no acute occlusions are found on an angio. It exactly mimics an ACS. The primary harm is from acute heart failure and stunning of the myocardium. Also can present as cardiogenic shock. Sudden onset of ACS-like symptoms, more from stress. We need to find which is the stimuli which causes this. There is no way to rule out MI unless all patients go for cath lab. So what are our tools for diagnosis addressing for an MI? Clinical correlation is the most important. Any suspicious ECG finding should be matched against patient presentation and physical exam. History, and with risk factors does support MI, smoker, diabetic, hypertensive, etc. We should delve deeper into history of the patient. If there are any old ECGs, extremely valuable tool when available for establishing baseline. And serial ECGs, repeated 12-lead ECG may reveal dynamic changes with time and treatment. We have more tools in addressing this. We have supportive ECG findings, which are subtle red flags. We can always get our expert consultation on panel. We can also rely a little bit on computer interpretation to raise our ears and broaden our eyes to pick up these patients early on. The signs that point to MI are significant, which means more QR relative to QRS amplitude, contiguous. You should know your coronary arteries to understand which occlusions make anatomical sense. Reciprocal changes and clinical correlation are a must. And a silent MI, 1/3 or 1/4 of patients usually will have no complaints or usual complaints. There will be elderly, diabetics, female, cardiac history, more likely to present atypically and have worse prognosis. So, which are the more signs that point to MI? Changes on serial ECGs. Mimics are typically electrical stable patients. We must obtain an initial ECG prior to treatment. We must perform serial ECGs, and one of the best tools for distinguishing STEMI versus mimic is still an ECG, which is serial. And we must find if we have an old ECG at hand. Bringing it all together, summarizing, we must obtain an early 12-lead ECG before treatment if possible. Before that, obtain an in-depth history and a good physical examination. On the 12-lead ECG, are there any ST wave changes? How profound are they? What is their morphology? Are there any reciprocal changes? what do you think and what does the computer think, which is very important because nowadays the AI algorithms will give a diagnosis to you. So we need to think in our brains, how is our pattern recognition happening at that point in time? Does the ECG support an alternative diagnosis? Would it explain the chief complaint that the patient has? Is it more or less likely than an MI? If likely, what is the probability of a comorbid MI? Is there any chance of an alternative diagnosis that is or are more pressing than STEMI, like an aortic dissection or advanced hyperkalemia in a CRF patient? We must obtain serial ECGs to guide or confirm our diagnosis. In conclusion, how do you make sense of different mimics of ECG? Start with patient history and background. Consider the complaint. Is the patient young, old? Are there any risk factors? Are there any past procedures which have happened? Is there any provocative event? How likely is congenital pathology? Is there an old ECG available? Consider the complaint. Is it typical for MI or more consistent with other etiology? And thereby, we'll be able to come to a diagnosis. Thank you very much for this patient listening. Thank you very much, sir.
Thank you, Nilay. That was very nice, lucid talk. Simplicity of one diagnosis at a time, and so many nice ECGs were put up. I hope our audience appreciated the value of understanding when these ECGs, these are ECGs which you actually land up seeing, and it's at that point when we need to make a decision that, look, is this something we need to immediately take to the cath lab, or we need to just say, look, wait and watch. And I want to put everybody in a situation where a patient is there, a 45-year-old. He's come to the emergency with chest pain. It may not always be severe chest pain. It may sometimes even be gastritis kind of pain, epigastric pain. And we are telling this patient, look, your ECG showing a heart attack. You have to go to the cath lab now. So this is when we ourselves as clinicians, consultants, doctors have to be absolutely sure that this is the right way forward. And we are talking about a life-saving decision here. It's not like something which we can say, chalo, let's wait for 1 hour, let's wait for 3 hours, let's wait till tomorrow and take a call. That's why some of these ECGs, which are really our day-to-day ECGs, we need to understand if these are some things which we need to take seriously or not. Nilay, I've seen people who've come to me with a ECG done in a health checkup, let's say 2 days or 3 days ago, where an ST elevation MI coincidentally picked up on a health checkup in a long-term diabetic patient without any symptoms has just gone missed. And similarly, we have patients who have a LBBB on a routine ECG, and they are brought to us saying, "Okay, this patient is getting a heart attack right now, do an angio." So let's take that thought forward. And what if you have, Nilay, a patient is in front of us, 45-year-old young male with some chest pain. Let's not say typical chest pain. Typical chest pain is easy. Vague chest discomfort, and he has on ECG an LBBB or an RBBB, and we don't know anything about his past. So now how do we approach this? Does every one of these patients needs to be in the cath lab in 10 minutes?
No, absolutely not. So I completely agree to a point. All of us in our clinical practice at some point in time have come to these kind of scenarios where and unindicated, when really it was indicated, it wasn't done. And when it was really not indicated, it has been done. So that's where this talk becomes very important and relevant. So when I encounter such patients, I usually tell them that each of the cardiovascular tests that we have looks at the heart in different way. The ECG looks at the heart in different way. The echo looks at the heart in different way. The TMT looks at the heart in different way. We have troponin and I and troponin T to help with us in our diagnosis. So, and most importantly, I think history. I can't overemphasize this. I think when we give some more time to history, maybe 5 minutes extra than what we usually give, patient is telling us the diagnosis. Patient is actually telling us what's it. So our brains will have a better pattern recognition. So my first slide was pattern recognition. how do we recognize these patterns over a number of period of time, years that we have seen patients? There's a pattern which is formed, and we usually put these patients in certain boxes in our brain. So when we have a better pattern recognition modules in our brain, we will advise the right next test which is there. Not every patient who is 45 with an LBBP needs to go to the cath lab, for sure. But if there is a patient who is a chronic smoker, is a diabetic, is in his 50s, and has an LBB with some chest discomfort, with some dyspnea on exertion or chest, and corroborative findings of other tests, then I think I would suggest, okay, we need to invest. And I will not rush the patient or make them panic unnecessarily. That's also one thing, because we need to triage them. That's why one of the slides included, is it okay to over triage certain patients? Perhaps yes, but there are certain patients which we need to go easy. We can tell them, okay, let's take it easy. You are okay. You're doing fine. Yes, there are some changes, and we may need to investigate you in a couple of weeks now, maybe 7 days or maybe 5 days. You need not rush the cath lab right away. But yes, you need to do these tests, inform these tests to me, and we'll take it forward from there. But there are certain,
I think like you're saying, these patterns, they're so important because it's a risk evaluation, the background, the history, and then what is in front of us. That doesn't take more than 2 to 3 minutes if you actually think about it. What is the
absolutely,
type of chest pain? Do you have diabetes, BP, smoking? Do you have any family history of heart disease? These questions are answered in 2 minutes. Now,
absolutely,
the thing is, K, I also want to add one thing to your pattern recognition because that's a very, very different approach that you've offered us. Our patterns sometimes need to evolve. Now, in 2025, a pattern is different from what it was in 1995. So in
absolutely,
1995, for example, a 40-year-old female would never have been thought to be a case of an MI.
correct,
But in 2025, whether we say it's because of COVID, because of stress, because of pollution, because of various additional risk factors that we have, today our patterns, that means the one that Nilay and I see, are different from what our seniors have seen in 30 years ago.
absolutely, absolutely.
So we should also understand that while these patterns are important, the patterns need to evolve. Pre-COVID, post-COVID is a very big difference in these patterns also, number one. Number two is the next question I have for you, Nilay,
Yes,
is you have this same 45-year-old chest pain, LBBB. The first thing that our departments do, emergency departments, is send a point of care troponin, CPKMB, and in little higher centers, you get a 2D echo. Now, what is the reliance on these two tests, the cardiac markers and the echo? First question, even a slightly positive cardiac marker test, is it reliable? And number two, is the negative cardiac marker reliable? And next question, how much value do you put on a 2D echo?
okay, okay. So lovely questions, very practical questions. I think so. My first approach to such patients with a say 45-year-old LBBB with certain vague complaints of chest pain, I wouldn't mind sending first troponin. Honestly, I wouldn't mind sending because see, at the end of the day, I want to save the myocardium. For me, time is
Yeah,
muscle.
Nilay, we are talking practical. We all know textbook wise 8 hours troponin takes to go up.
Yeah,
But we are not talking. We are talking now. You are called when the troponin is there.
I
So
will.
yes, this
Yeah,
happens. So
I
I
will.
want a practical answer, not a theoretical answer.
Absolutely. I will go for a troponin. It's a young patient. I don't want to lose that patient for by missing a diagnosis. A troponin, which is a very important and interesting test because it is released from a damaged heart muscle. We at least get to know there is some activity happening. Now, the next question after say troponin is you said positive. And the positive in a very minimal range. It's not a wait, we can always wait. We can always go for another troponin. After a 3 hour, we can go for even if the guidelines recommend say a troponin after 6 hours, I would go for a troponin after 3 hours and see if there is a rising trend of troponin. If there is no rising trend of the troponin, I'll just stay put. I'll not over investigate that patient. It could be because troponin is, despite an important test, It could still be due to some other reason. It is still a non-specific marker. So like CPK is a very non-specific. I have so many patients who go to gym and they do a lot of gymming in a day and the CPK comes very high and they panic. They come to me and they say, what do I do? Do I go for an angiography? I said, no need. You see the background. If the patient has come after a hike or a trekking where a lot of activity is involved, and the CPK is likely to increase because that's what the nature of that marker is.
So I just want to put a rider here for all our listeners. We are not talking about that severe typical chest pain patient here. Severe typical chest pain with LBBB at 45 is you don't even need to wait for those troponins. Then you have to immediately take the patient. We are both discussing where the pain is not classical, where you've got this LBBB, you're clinically in two minds. Am I right, Nilay?
Yeah, yes,
And
correct.
in that situation, a tiny elevation of troponin sometimes has to be taken with a pinch of salt. So your clinical judgment still holds value. So
Absolutely.
if after this, what is your now? Will your echo change your diagnosis here?
Correct. Correct. Yeah, of course. I think echo will help me to see if there is any regional wall motion abnormality or whether it is actually because of the LBBB itself, where I see there is some paradoxical movement of the septum, which is usually seen on an LBB or an RBB. I'll be very cautious. I'll look at the whole picture. I'll look at the patient and I'll not treat the echo. I'll not treat the troponin. I'll treat the patient. That is a better way to put it. Let's not treat the labs. Let's not treat the investigations. We need to treat the patient. So when the patient comes and if he has, I'll tell him what it is. And I will want to look at the echo and view in terms of whether there is a regional wall motion abnormality and then take the next step in investigation. Because
Right.
it's like a
So I think what you're trying to say is that a STEMI will always have a regional wall motion abnormality for which you need to take the cath lab. So if
absolutely
you have a normal, if you have the same 45-year-old chest pain, LBBB, but the 2D echo is absolutely normal, then the likelihood of a STEMI is very low.
correct. Correct.
Whereas if at all you say get the same patient with the non-specific chest pain and LBBB has a regional wall in the LAD territory, then you should take them for a procedure immediately. So your echo is a
Absolutely.
very
Absolutely.
important point of your pathway in your decision making. Now
Absolutely.
the next
Absolutely.
question is a very interesting question, which I think is very important from Dr. Sai Kumar Nile. Recent onset chest pain of 1 hour duration in the same 45-year-old male. He's got chest pain. No ECG changes. A normal or a nearly normal ECG lets no ST elevations for sure. But the 2D echo has a regional wall motion in the LAD territory. Now, is this a patient who we can thrombolize or take for a PAMI or not? Very interesting question, because the question is on thrombolysis. So, remember that while Nilay ponders on this, I want to just tell everyone that ST elevations are the key for thrombolizing a patient. The
Absolutely.
only other time you thrombolize a patient is when you have a posterior wall where you've got ST depressions. And in this case scenario, where you have no ST elevations, but chest pain and a regional wall, it's not a STEMI, but it's probably a N STEMI.
Correct. Correct.
In this situation, you don't want to thrombolize the patient
Sure.
because you don't have ST elevations. ST elevations tell you that there is a problem with acute problem with the blood flow, acute 100% lesion. But the regional wall motion tells you that there has been chronic or there has been ischemia ongoing. This could be a pattern of a stuttering MI also, where their ECG now is normal, but they're stuttering into an MI. So
Yes.
if you have a very typical chest pain with regional wall motion, rather than thrombolize them, the better option would be to take them to the cath lab and do an angiogram and see the blockage and then fix it. Because the regional wall motion in the LAD will most likely represent a coronary lesion. This is a situation where you don't thrombolyze, but you do an angio immediately. So,
Absolutely.
and also, whenever there is a doubt, then you have to prefer to do a invasive coronary angio and look at the arteries rather than thrombolize the patient, because thrombolysis, whatever you say, is a blind procedure.
Yeah.
Thrombolysis is not a 100% efficient procedure. It has a success rate of recanalization of only around 70 odd percent, even with the best agents. So
Correct.
you will still have those rescue procedures required. So when you have these doubts, the option should be towards invasive angio.
I agree.
So, Nilay, do you have any views on this?
I completely second that. Without ST, so to the question, without ST elevation, no thrombolysis. In this patient, even if there is a regional wall motion abnormality and no ST elevation, I will not thrombolyze this patient because it does not fulfill the criteria of ST elevation. No thrombolysis. Second, yes, the same person has asked, shall we repeat the ECG after 1 hour? Yes, you could repeat the ECG after 1 hour. That's not going to go waste. It could possibly, as you sir rightly said, it could be a sort of stuttering MI. It could be just started to evolve that way. So it could just lead to ST elevation in a while. But at this point, I can't overemphasize the need for loading doses. Sometimes just the simple loading dose of 300 ecosprin, 300 clopidogrel, 80 atorvastatin, and 1 shot of heparin. It does wonders to such patients, even if you see regional wall motion abnormality with normal ECG, surely load the patient. Loading a patient has not done harm, but it has done a lot of good to patients who have actually got an occlusive myocardial infarction. So I think we have to go individualize patient to patient basis, and no thrombolysis until there is, you see an ST elevation and a pre-test probability. You see the patient, the history, the ECG, the echo, the troponin, and then take a call. You need not wait for troponin for loading also. If you feel there is an there's some non-ST elevation MI, load the patient. If you feel there is an LED territory echo RWMA, load the patient. No problem. I think loading has done wonders to myocardium.
Absolutely.
Yeah, so that's,
So I think that is an excellent thing to say, that this is also always a question we get, that is, do we give a patient with chest pain Disprin or do we give them Sorbitrate? So what Dr. Nilay has just said is that loading with a Disprin is a very, very important step in this process of managing your chest pain patients. Okay, so this is a very important thing, uh, because loading, they say that when your patient walks in to the emergency with chest pain, within the first 10 minutes they should get an ECG. And even if the ECG is normal, a Disprin can be given comfortably, just in case it is something related to ischemia, because that is the safest way to save a life. Disprin and aspirin has a mortality benefit like no other drug. Now, I think, Nilay, this has been a fabulous session on STEMI and STEMI mimics, and I sincerely thank you for setting the tone for this meeting in such a nice, comprehensive, and very simple. I loved the diagnosis, the ECG, the visual impression of this STEMI mimics was just beautifully brought out by Nilay, with some excellent talks and excellent concepts of pattern recognition, and how we need to look beyond just the test and look at various methodologies, like a history, a good history, as well as the background of the patient, to decide a CKD patient with potassium of 8 and hyperkalemia can mimic a STEMI. A patient who's got uremic pericarditis can mimic a STEMI. A patient who's got a LBBB, RBBB can mimic a STEMI. So we have so many
a patient in an
lovely
infectious
new.
a patient in an infectious ward can mimic a STEMI in terms of a stress cardiomyopathy. So the background
Correct. So
is
so
paramount.
many mimics. is paramount. So I think, because Nilay set such a lovely tone, I think that, we are now out of time and we have to end our session today with great thanks to Nilay and his lovely talk, as well as to API and Jaslok and the logistic team from Medgami, as well as Avinash from Jaslok for all the logistic support. So the big thank you to that entire team. And I think what we will do, Nilay, is that we'll set up the next two rounds of our cardiology clinics. I want to take this STEMI discussion forward. I want to have maybe a talk on antiplatelets that are used in STEMI, and then we'll have a second talk on PAMI versus thrombolysis. When to intervene. So I'm going to invite Dr. Nilay to be part of our moderator panel in the same session, so we can take this. He's set up the tone so beautifully that I think we'll take the discussions forward for the next two sessions as well.
Sure. Thank you very much, sir, for this opportunity.
All right. So a very happy Diwali to everyone, the entire team, and to all our listeners. And we will have this put up on recording in our Medgami app. So we do invite everyone to keep looking at the recordings. And with that, I'll end the session and thank everyone for their attendance, their listening, and for all the support from
Thank you
API,
very much.
Jaslok, and our logistic team. Thank you, Nilay.
Thank you, sir. Thank you very much. Thank you.
Thank you, everyone. Thank you.